We're 12:05 now, Marilyn.
Yes.
You're welcome to start.
Okay, well, good afternoon and welcome everyone. My name is Marilyn McDonald and I'm a member of the CASN Research and Scholarship Committee. On behalf of the committee, I'm happy to welcome all of you to the January session of the 1819 Lunch and Learn series. I'm sure many of us are familiar with this concept where faculty come together during their lunch hour to share with one another projects they're working on and to dialogue and discuss methodologies, successes, challenges in their work. This series is intended to serve as inspiration and a networking opportunity for participants while recreating the collegial feel of the Lunch and Learn. In this fourth session of the 1819 series, we will hear from Dr. Rosemary Wilson, Associate Professor at the School of Nursing and Associate Director of Graduate Nursing Programs at Queen's University. Dr. Wilson's also a nurse practitioner in chronic pain at the Kingston Health Sciences Center, a nurse for 25 years and an NP since 2000. Rosemary has practiced in diverse settings, home care, acute care medicine and surgery, and outpatient specialty care, and has recently been practicing in a referral hospital in Rwanda. She has expertise in opioid prescribing, deprescribing, and risk mitigation that is the result of her practice, her research program, and from work she has done developing educational materials for controlled substance prescribers. Dr. Wilson is the Deputy Director of Practice for the Queen's Collaboration for Healthcare Quality. The work that she does with the collaboration includes the generation of knowledge syntheses and translation for practice. Her research is focused around acute and chronic pain and spans from pluralist, clinically oriented research to knowledge translation and quality improvement. If she had to declare a methodological alliance, it would be qualitative, but she lets her research questions drive the activity. During today's webinar, and you have the title before you, which is very engaging, Dr. Wilson will describe an ongoing interdisciplinary project in Rwanda that's focused on improving the quality of pain care in local referral hospitals. The project provides an exemplar of local champion empowerment for evidence-informed practice improvement, resource allocation, and research capacity building. She will review her team's successes and challenges and reflect on their learning for future stages of the project. Personally, I had the great pleasure of a nice conversation with Dr. Wilson before she headed off to Rwanda. So I'm really excited at the prospect of today's presentation and the Q&A because you have an image of what might unfold, and now I'll actually get to see and listen to what did. After the presentation, we're going to have time for questions. And so to submit a question, use the question and answer function on your screen. And be sure and don't forget to hit the send button once you write your question. So now it's over to Dr. Wilson.
Great. Thanks, Marilyn. I'm really excited to be here to talk about this awesome project that I just have the good fortune to be a part of. Actually, last year when I was on academic leave, I did a presentation from, I was in England at the time, for CASN for the Lunch and Learn on systematic reviews, and somebody was asking me about the global application, and so that's how I got asked to do this talk as well. So last year when I was on academic leave, I spent almost 3 months in Africa, 2.5 of those in Rwanda. It was my 4th visit to this wonderful country, and I just feel so fortunate to have had the experience. So a moto is a way to get around. In Rwanda, there's an awful lot of motorcycle taxis that you can jump on. I was never quite brave enough, but perhaps in the next trip I will screw up my resolve and go, because I understand it's quite fun. It's important when talking about this project to acknowledge our funders. The project started off in 2014 with the Canada-Africa Research Exchange grant from the CASF, Anesthesia Society International Education Foundation, and then a subsequent grant from the Louise and Alan Edwards Foundation from within CASF. I was asked to be part of the project by my colleague, Dr. Joel Parlow, who's the head of the Department of Anesthesiology and Perioperative Medicine here, and his co-principal investigator, Anna Johnson. The project was ongoing when I entered into the discussion with Dr. Theogen Twaijiru Mugabe and Dr. Gaston Nyirajira, as well as other additions, my colleagues David Goldstein and Elizabeth Vanden Kerkhoff, Ryan Mahaffey, and Dr. Rylan Egan. We're also indebted to our research assistant associate, Jessica Baumhauer, and our previous research assistant, Jennifer Hirosh, who did quite a lot of work on our behalf. So for those of you who haven't been to Rwanda, I can tell you it's a small little landlocked country above Burundi, below Uganda, and next to the Democratic Republic of Congo. What you may remember about Rwanda is probably not the lovely place that I have been to. Rwanda in 1994 experienced one of the worst genocides in history, where almost 1 million Rwandans were killed in the space of about 6 months. Our Canadian General Romeo Dallaire was there at the time, and if you've had the opportunity to read any of his books, you'll have a sense of what these very resilient folks went through. And certainly when you go to Rwanda and you experience the lovely, wonderful sense of how Rwandans treat each other and their notion of we are our Rwandan, you can really be you're humbled by the sense that these folks have picked themselves up and moved ahead after such a terrible tragedy. So to travel to Rwanda takes quite a long time. It's hours and hours and hours of flying and a number of connections. And for somebody who'd never been to Africa before, it was definitely an awesome experience for me when I went the first time. So this is the Sahara Desert. They're flying over here. One of the reasons that we started this project, Canada partnered with Rwanda early on after the genocide, because they were in need of professionals to help them with their healthcare. At the time, the Rwandan anesthesiology staff there were 2 for about 13 million people, just to put that in perspective. And so CASF, the foundation from Canada, worked alongside many other countries to help the Rwandan healthcare system to bring up a program for anesthesiologists, alongside many other initiatives from many other countries helping to increase the number of nursing staff, pharmacists, physiotherapists, etc. We're all aware that pain relief is a fundamental human right. So human rights in 1948 declared that, and recently in the Declaration of Montreal, it was affirmed that it's a global human right. So in the interest of promoting pain care within the Rwandan context, we engaged in this project to increase the researchability for the individuals that were working within the referral hospitals, as well as the on-the-ground clinical pain care. Because it's important when you start these projects to make sure that it's sustainable. So individuals who are part of it need to be given, or need to be be engaged in developing the skills that they're going to use ultimately to keep things going. So we use the knowledge to action framework, which is partially visible here. My apologies, that's Ian Graham, Joe Logan, Mark Harrison, and Joe Tetro and others. This is something that we use quite a lot within our QCHCQ here at Queen's. We do a lot of knowledge tailoring, and so when we came to the project initially, the practice issue and problem was brought to us by the CASN crew who had been going back and forth to Rwanda for quite a long time. So my colleague Joel Parlow said to me, we're teaching the staff consistently about how to assess pain, how to manage pain, what are the different pharmacologic and non-pharmacologic methods we can use to improve pain, but we haven't gotten anywhere. We go back and the issues are the same. So do you think you can help us? And one of the things that I know from my experience working as a nurse practitioner in pain care in multiple settings now is that you have to engage the individuals when you're that are doing the business of healthcare. So nurses, pharmacists, PT, OT, even assistive personnel at the bedside, in order to tailor the knowledge and to make sure you understand the context. So that was my entry into the project. Going to Rwanda requires quite a lot of vaccination, so just beware if you're going to go there. It is an interesting project to get yourself up to speed in terms of vaccination. So this is my colleague, Dr. Gaston Niragira. Gaston is the most incredible local champion. Without Gaston's help, there is no way that we could do any work in Rwanda. And so some of the challenges that we face when we're trying to figure out what's going on the ground in the context in these referral hospitals is that there are multiple languages spoken in the clinical environment. So the official language of documentation and of healthcare is English. But this is a French-speaking country and a Kinyarwanda, which is a local language speaking country. And Kinyarwanda is I understand it's a Bantu language. It's similar to some of the languages in the region as well. And a lot of my colleagues in Rwanda are multilingual. They also speak Swahili and other dialects that are from other neighboring countries. And so there are multiple languages spoken. And it's very difficult to bring your point across if you don't have a skilled translator who is going to be able to identify the subtleties in the language between what you're saying and how it's being translated. And in some cases, there are not words for some of the things that we take for granted in English. So I think that's an important point. On the right, you see my colleague, Rylan Egan, who is a specialist in quality improvement and a faculty member here at Queen's School of Nursing, talking to our pain management steering committee about quality improvement. And with Gaston there to help us to translate, that was a tremendously interesting experience. So the initial project was informed by some focus group work that was done by Anna Johnson and Ryan, Rylan, and Theogen and Joel on their first trip. And those early focus groups told us that they were having troubles with documentation. They were having troubles with getting access to the medications that we were recommending that they use. So it was very difficult to advance the idea that balanced analgesia, which has long been established as the best way to treat acute perioperative post-traumatic pain, is the way to go when you can't get access to morphine or any other potent opioids. It's difficult sometimes to get access to their version of acetaminophen, which is paracetamol, or even in some case non-steroidal anti-inflammatory medications, let alone local anesthetics or other agents that we might use, or block needles. So it was very important for us to make sure that we understood what was the resource model present in the referral hospital and what could they actually get access to. in order for us to be able to tailor that aspect of the evidence to make some recommendations that they could work with in a more realistic way. So that focus group informed a second visit that we took. So this time it was Elizabeth Van den Kerkhoff, Theogen, myself, and David Goldstein. And we used a questionnaire that we'd used many, many times before in Canada, the Theory of Planned Behavior questionnaire, that we contextualized to the Rwandan context, that was in a way that was based on the original focus groups and in discussion with Gaston and some colleagues from Rwanda here at Queen's. And so we were able to go and administer the questionnaire across 2 referral hospitals. So referral hospitals are the large hospitals in Kigali and in the southern province, Butare. These are what would be considered to be a tertiary care facility in Rwanda. And so we had a fantastic turnout. Nurses, nurse anesthetists, anesthesiologists, intensive care physicians, surgeons, administrative staff, pharmacists, physiotherapists filled out a questionnaire. And although we did our very best to contextualize it, one of the things that we found in that study was that we had a beneficial response bias. We had lots of 1s and lots of 7s in our Likert style questionnaire items, which was a learning aspect for us for sure. But in this questionnaire that we contextualized, we also had a number of questions about what were the barriers and facilitators to actually carrying out the process of pain management, from assessment to reassessment following intervention. And there were a number of aspects of what we learned that surprised us. And one of them was fear associated with the adverse effects of opioids, and really their understanding of what monitoring was and who was responsible for what. So knowing that information was key for us to develop an intervention to help. So you can see how the timeline has gone up to now. 2015, there was a problem identified consistent with the KTA framework that I showed you before. We knew that they needed new pain care tools, they needed some knowledge, and they definitely needed some support. So we partnered with our other colleagues at Dalhousie and McGill to develop some tools and resources to do some direct training, specific training that's been tested in global and low resource settings, and then to start with practice auditing. And so we did have the opportunity to have some pretty good outcomes here in terms of practitioner awareness of the tools and information. So we made lots and lots of teaching material that was posted all over the hospital, and participants had pocket cards that they could refer to quickly, which gave them some reminders about some of the assessment tools that they could use, when to assess, half-life, onset to effect and half-life of different medications, and different medications to try in different circumstances. And we used quite a lot of important evidence and clinical practice guidelines tailored to their environment, so using their medications, their process, and their workflow. And we began some baseline data collection as well to find out really how things were at that stage in terms of their ability to assess, to deliver medications and treatments for pain, and to follow up. So in 2017, I was there with my colleague Rylan Egan and Jessica Baumhauer, and we began quality improvement, because during this time, between 2016 and 2017, we started to talk about how quality improvement and a quality improvement mindset fits well within the knowledge to action framework, and how we could use QI to empower our local champions to be able to take their data to the administrators to lobby for additional resources in terms of personnel medications, treatments, and any kind of equipment that were required. So one of the important things that we learned, so alongside this project, this hospital in Butare was attempting to become one of the first hospitals in Rwanda that was accredited through COSASA, which is the accrediting body that has been contextualized. The standards are contextualized to lower resource settings. So one of the processes that we uncovered when we were attempting to implement this stage of the project was that the COSASA guidelines required that each of the areas where a change was going to be made had a clinical practice guideline to fall back on, which was, I think, perhaps not recognized prior to digging into what was going on at the hospital by all of the team members, but when we discovered what the process was, we ran with it. So Gaston and I, along with some assistance from the Australian, New Zealand pain management guidelines, which many hospitals use now, we were able to contextualize that set of clinical practice guidelines for acute pain care to the Rwandan context, using some of the evidence that's available and our previous investigations. So here's a great picture of Liz and Gaston. So contextualizing evidence takes a lot of time, and it's very trial and error. Gaston spent hours and hours and hours looking at the difference between the words of intend and wish to or want to, and how when they're translated to Kinyarwanda. So those are important factors. Language matters, particularly when you're trying to send a message, and the way you present the information matters, because if it's not your culture, subtle cues and the way you speak and the way you present information may not be appropriate to the setting. And so that is so important to remember all of the time. You have to keep your ears open for advice in every circumstance when you're doing this kind of work. So when you do an analysis of where things are going prior to engaging, moving KT into QI, or bringing QI into KT, you have to look at the strengths and weaknesses and opportunities, etc. You know, the old SWOT analysis. So this center where we were working has really great strengths and had great strengths to begin with. They had some materials available. The Rwandan government had set out national guidelines for pain management in the previous year. So we were able to build upon that and the momentum that brought to the clinical environments. They'd done some preliminary training before, and a pain team had been established. So we used a nurse anesthetist and an anesthesiologist, much like, sometimes the audio is coming through. My apologies. So somebody will have to let me know if I'm moving back. So the pain team had an opportunity to do some coaching, to do some auditing, to get in there with patients and start to mentor patients, because what patients' expectations are equally as important in establishing what the context is, as well as communicating with the hospital-wide quality improvement committee, which was a huge strength. Great communication pathways here. So we also had very, very engaged practitioners. So these are 3 nurses from the surgical unit who were very, very happy to meet with me, and were very, very lovely and very responsive, and also very honest about what they were experiencing in the environment, and what we could do to help fix things. So on the weakness side, I would prefer to talk about this more as challenges, because they put their health care system back together, and so things were not as streamlined as they could be. So there was really no process for systematic data collection and any process for reviewing any kind of data collected in the clinical environment. And that's not just a challenge in the developing world, it's a challenge all across the world, I would argue. It's important to collect data when you're implementing something, you're trying to implement any kind of practice change, because how are you going to know if you've produced any benefit or haven't produced a benefit? And you always need to be able to justify the resources that have been allocated. We knew that there was really inconsistent practice and inconsistent documentation. And I cannot emphasize enough how important it is at the clinical end of things to look at the patient charts. Because the documentation and the difficulties the nursing staff had, yeah, and the physician staff as well, in actually navigating the documentation tools was really part of why we were not seeing any early success after teaching. The charts were in 3 languages, so in English, French, and Kinyarwanda, and oftentimes the nursing staff had to chart in 5 different places, one single medication administration. It was quite a complex documentation process and used an awful lot of time. And so in some circumstances, medications were given and not documented, or documented and not given, or it was very difficult to tell what dose was given, or even some circumstances what medication was given. And I think the nurses found it quite frustrating. There were practice standards available. Rwanda does have a registering body, but the practice standards were not as ubiquitous as we were certainly used to. So that was another issue that we had to deal with. And engagement of the frontline practitioners can be difficult. At times in the environment, there were 2 nurses for 30 patients. In some of the referral hospitals, or all of the referral hospitals, the family members are responsible for much of the bedside care. So in some circumstances, the family members give the medications as well, because there aren't enough nurses to do the work. So it was sometimes difficult to get individual staff members to get engaged when they were mostly practicing, going from one crisis to the next bit of crisis. So we had lots of great opportunities. There was a move towards the integration of our international documentation standards and processes, so use of things like medication administration records. There was no problems establishing the committee to oversee and innovate for best practice. Really easy to bring in the quality improvement mindset, because they were looking for accreditation, and the staff and our colleagues there were ripe for this information. And we were able to bring into alignment our ideas with the national pain management strategy, which was key. And the local hospital was very interested in integrating the pain unit into the hospital structure. So that was a real opportunity for us as well. We had buy-in at the administrative level, which, if you've done any of this work, you'll know is key no matter where you are. Ongoing threats. We needed to make sure we had consistent communication with the accreditation facilitator, who was a very well experienced and established individual who had lots of very important things to say. So we needed to communicate a lot with him. Oftentimes what happened was the pain team members who were assigned to be working that day were allocated to other areas. And so sometimes there were no individuals available, even for auditing or coaching. So that's an important thing that we are currently addressing. And we knew that there was no systematic performance visualization, so they couldn't really see how well they were doing to keep them on the path of sustainability. Here's another couple of great pictures. That's Jessica Baumhauer, and she's talking about our baseline data to our QI um, steering committee. And on the right, you can see that Rwandans are highly resourceful individuals, and many things are carried on the back of bicycles, including people, beds, and chairs. So these folks are incredibly well fit that ride these bicycles. They're pretty amazing. It's a very hilly country, and the heavy things that they carry on their bicycles is pretty impressive. I can barely carry myself. So when we talked about performance visualization, what we started to do was get the staff at CASN, which stands for Centre Hospitalier Universitaire Butare, or CHUBS, or CASN as they call it. We get them to put some data into spreadsheets that were developed by Rylan Egan and stored on a web-based in a web-based folder. And then we would do the data analysis for them, and have been for the last couple of years. But without knowing the context, it's very difficult to have a look at these performance visualizations and make sense of them. So that's one of the important things. When you see 100% pain assessment done on post-op day 1 in one day, but it's only 30 charts looked at, or 30 instances looked at, or in the entire month of December 2016 without any pain assessments done. Well, that has more to do with the fact that there were no resources for doing the clinical audits in the month of December. So keeping that context in mind is key. However, these charts were very, very useful to the staff there, because when they started to see some movement towards doing the assessments and giving the medications in a numeric way, it allowed them to be able to cement the resource allocation with the administrative staff. So I know that many of you have seen the quality improvement mindset before, but this was important for us to be able to teach to the staff, and particularly to the steering committee for the pain management team and the quality improvement project. So making sure we know what we're trying to accomplish, how do we know there's a change, and what change can we make that will improve things. And also, importantly, plan, do, study, act over and over and over again. We help them to really flesh out their SMART goals, so the specific, measurable, agreed upon, realistic, and time-based goals for their project, so that they could take the data that we were giving them and continue to make SMART goals and work towards them. So here was one of the goals that came out of one of the meetings that we had with the Quality Improvement Committee. So everybody involved in acute care will participate with medication, dosage schedule, and pain assessment accreditation standards. With errors per case examined by April the 1st, 2018. And we are happy to say we got quite close to accomplishing that goal. So in the QI process, there are outcome measures, process measures, balance measures, and spread measures. So we were really interested in looking at the outcome measures. The process measures we were not quite sure about. That was part of the contextual aspect of things. And the balance measures were coming alongside to let us know what the unintended effects were, like resource use, and then spread measures. So one of the spread measures that we saw was that some of the other centers were actually picking up some of our ideas. I'm going to speed up just a tiny little bit. So one of the most important things that we did in this last project was to actually diagram out what the current process was for perioperative pain management, and contrast it with the proposed pain management process. So we actually physically walked through these diagrams with staff and then carried them out in the physical environment. So followed the patient through the recovery room to the nursing unit, to discharge, to see if our analysis of the pain management process was correct. And we had to do that quite a few times. I'm embarrassed to say more than a dozen. And that's owing to really the difficulty paying attention to the detail with the process, and the lack of consistency in many ways. And then we developed a proposed pain management process, which really helped us to be able to figure out what we were going to measure in terms of outcomes, process outcomes, and balance measures. So really, it's a difference between tactics and strategy in lots of ways. And so if the change impact is high and the difficulty is low, that's the best strategy to go after. So changing the documentation tool seemed to be the best place to go to bring on the change. So we were collecting data. This is an example of our audit sheet where we had process measures and outcome measures. And living amongst my colleague's family in Rwanda really taught me a lot about everything from how they eat to how they live their lives to how they rest to how they interact, which really helped me to be more effective bringing interventions into the healthcare environment. And this is me making ugali, which is fantastic. So aligning all of our interventions to the accreditation was also a very interesting process and an important contextualization. Being able to go through, I went through the entire of the accreditation documents and pulled out anything that had even the smallest bit of relevance for evidence-based practice in pain care to present to the staff and to senior leadership, in addition to the CASN accreditor. So as you can see, there are a number of different types of guideline statements, accreditation statements that are appropriate. And so going through all of these different sections, we were able to demonstrate that this is important, this intervention is important. And in doing so, we got their okay to go ahead. So we have implemented a medication administration record that fits with best practice internationally, but also with their practice. So using their medications and the way they do their documentation. I'll give you examples of that. We implemented something that looks very similar to a flow sheet we use here. And the staff there liked this flow sheet and were able to use it. They're still working on bringing it into more frequent use. It's currently part of the patient chart. But I think it's really helped them in terms of decision support and to deal with their fear about sedation as a result of the use of opioids for pain. So the other part of the plan was teaching the staff about using a documentation, teaching about the process of using a documentation, training auditors, and establishing the daily flow processes. So we did that quite a lot, and we implemented it. And we were able to go, Gaston and I were able to do pain rounds every day with the staff for almost a month whilst I was there. So as you can see, we're getting lots and lots of data from the staff in Rwanda, and we continue to bring information back to them. And I'm pleased to say that right now, Rylan and Jessica are in Butari working on the next steps of this project. So we are in the process of acting on our most recent results and making new strategies. So it's very important with a quality improvement mindset to keep in mind that it never stops. So we have to keep planning, doing, studying, and acting, and bringing in the new evidence and continually contextualizing and collecting that data so that we can make this a sustainable process, because we want to do with, but not for or to, in the global setting. So the next steps for us, we are going to hopefully spread the acute pain care program and the process that we've developed to one of the other referral hospitals in Kigali. And Gaston tells me that one of the things that's on the top of his mind now is to start a chronic pain clinic. So I can see that there will be a visit back to Butari in my near future. I'm also so proud of Gaston and his colleagues at Sashube, because yesterday they started their Zero Pain Conference. So 2 days at the Centre d'Accueil Boni Conseillé, where they're bringing in international speakers and local.
Oh, thanks so much, Rosemary. That was very, wow, valuable in so many ways. And what a journey you're on.
I should just add one small thing.
Nice
Gaston introduced me initially as Dr. Rosemary,
help us to see where
professor, and after a couple of times of him introducing
I want to invite all those attending to,
I took him aside and I said,
questions.
Gaston, I think you just need to tell them that I'm a nurse from Canada.
And I know that Rosemary will be more than pleased.
And then I said, okay, I want you to, maybe you can help me to actually tell them that I am a practicing nurse.
Them, and
I lay my hands on patients every week.
Time, so,
and let me tell you, that made all the difference to my ability to be able to engage with the staff.
16 people attending, and
because if they were thinking of me as a professor from another country, and not as a nurse who understands their challenges, I wasn't going to get the information that I needed to be able to help. Well, for sure, you're absolutely right. And I oftentimes I just shake my head and think this is not unlike something a challenge I have faced here in Canada. Resource challenges and
Just from my
staff
own
being overworked
interest,
and
Rosemary, I
documentation
couldn't help
processes
but
not
think
following workflow, and
while
those
I'm listening
contextual
to
aspects
this
are,
work,
just because
the
it's a
fact that
developing
here at
country doesn't
home,
mean that
this is certainly
their
something that
issues are any
continues to
different.
be challenging for us. And
They
so I
we
wondered
get
if you saw
morphine more
any
often here, and we
parallels
can
at
get
all
hydromorphone
in
and
terms
lots
of
of
your
other things, and we have
experiences
access to technology, but
in
there aren't enough
Canada
nurses to do the
and
business,
how they
then the
repeat
issues are the
themselves
same.
other places, and
So
how
you're
and
absolutely right.
what insights you might have on that.
Oh, Sahin, you've asked. Sorry, I can indeed, yes. So what facilitated the way we present knowledge matters? Well, I think being in tune to sort of the body language of the people that you're speaking to is half the battle. That notion that the staff were thinking of me as perhaps a professor that they had run into at school, or something of that nature. It was really easy to see that when I presented things in a particular way, they shut down. My colleagues in Rwanda are very expressive, so it's actually was quite easy to see with respect to their body language when I was doing a good job, and when I was not. And I'll be honest, I asked, I said, how am I doing here?
Can you see on the screen,
How am I
Rosemary, the
coming
comment
across?
from
Can you
Sachin?
be honest with me about what I can do to deliver this message in a way that it's going to be heard appropriately, and in a way that's culturally appropriate? Um, so really taking the advice of everybody who's willing to give you advice is key. You really do have to be humble. You are absolutely right. Um, Fish, how did I see culture and pain management in Africa? Well, a couple of things. I think that the expectation of patients around pain care is not the same as we experience here. Um, I think we all come across patients who don't want to bother the nursing staff or don't want to bother the physicians about pain, but more often than not, I think our patients are relatively relatively good at advocating for themselves in terms of good pain care, at least most of the time. Uh, that is a challenge. Um, the patient's expectation is that they're going to have pain, and the problem is that when they expect they're going to have pain, that means that they're going to stay still, and they don't do the things that they need to do to get out of the hospital and get away from healthcare providers. So that is an issue. That was certainly an issue in Rwanda. So teaching the patients is equally as important as teaching the staff. Um, pain pain care is um, not about stopping pain. It's about making it comfortable for patients to do what they need to do to get better. And so that's a really, really important message. I think regardless of what culture you're in, but certainly was a challenge for us in Rwanda. So helping also the staff to see that treating patients' pain well meant that they got up and they moved and they coughed and they deep breathed, and they actually were able to get out of the hospital, so free up a bed for somebody else. So it's actually becomes a resource issue as well. So thanks for that question, Fisha. From an NP perspective, how is my role viewed, Irina? Well, they don't have nurse practitioners there. Probably the closest thing would be nurse anesthesia. It's a post-baccalaureate role for them there. When I actually did get registered in Rwanda, the National College of Nursing and Midwifery, and they didn't quite know what to do with me. So I got a registered nursing registration in Rwanda while I was there. There, when the nurse anesthetists practice independently, they actually are practicing under what loosely looks like medical directives. So they do order medications within the context of the operating room, but as soon as they're outside the operating room, they require the physician to come and sign their orders right away before medications are given. So in terms of nursing independent practice, that's all there is. However, I think if you move a little bit away from the referral centers, nurses do work quite independently and autonomously because there are no other healthcare providers. So that's also something to consider. I did have some of the nursing staff and some of the faculty from the University of Rwanda asking what I thought about the implementation of advanced practice nursing role in Rwanda. So maybe that's something we'll do in the future as well. Thank you for such great questions. Well, moving along with the COSASA accreditation means examining quality. And so they were more looking at sort of a quality assurance point of view, which is a little bit less participative, a lot less participative than quality improvement. So it was there, and they certainly were interested in bringing it forward. It was just up to us to convince them they needed to go QI instead of QA.
The other thing I was wondering, Rosemary, was the extent or the pervasiveness of the quality improvement movement in the general area you were in and in the country as a whole. Okay. Okay. Okay, so looking to see if we have anything else there. Oh, you have some great comments, Rosemary, and I would certainly echo all of those. I think this has been a very valuable webinar, and I want to thank you very much for giving up your time and sharing this, and for the work that you're doing, and also to all of those who participated today. And I want to remind folks that after the webinar, you're going to receive a short evaluation survey regarding the session. It shouldn't take you any more than 5 minutes to complete, and it really makes a big difference in terms of thinking about how we structure this series and the future of the series. And also, a recording has been made of the session today and will be available on CASN's YouTube channel, and also will get circulated to participants in coming days. And feel free to share the link once you get it. Thank you once again to everyone, and on behalf of CASN, who hopes you'll consider attending our sessions in February and March. And visit CASN.ca, Lunch and Learn, for complete information. Julia, any closing comments?